Hi, I'm Dr. Lowry Barnes, and welcome to UAMS Health OrthoChat. I think you're going to really enjoy this series of chats where we talk to our orthopedic surgeons about what they do and what they have to offer patients just like you. We are so fortunate tonight. We have Dr. Ben Stronach, one of our hip and knee surgeons, who's going to visit with us about what he does on a daily basis and just who he is and how he might be able to help you. Ben, welcome.
Thanks, Dr. Barnes. Glad to be here.
We are glad to kick off this series with you, one of our newbies. You've been here now how long?
I've been here almost a year and a half. Came in December of 2020.
Great. We know our audience doesn't really understand what it takes to get to be at your level. So why don't you tell us about college, med school, how many years, and the training you've had to do to become a true specialist in hip and knee surgery?
Sure. So I went to college at Rhodes, which is just right down the street in Memphis. Was there for 4 years. I then went on to get a master's. That was another 2 years. I then went to medical school, did that in Birmingham, Alabama. That's another 4 years. I then went on to train in orthopedic surgery, which is another 5 years. And then I went to Utah for a fellowship in hip and knee replacement, which was another year.
So 16 years after high school before you're ready to start practice.
That's correct.
It's impressive and well worth it because now you have that much more knowledge to share with your patients. And we were very fortunate to have you come join us. Why don't you tell us a little bit about your background before you came here?
Sure. So when I got done with my training in Utah, I went to Jackson, Mississippi, and was an arthroplasty surgeon or joint replacement surgeon at the University of Mississippi Medical Center for just over 10 years.
Great. And I know you do both hip and knee replacements, but tonight we're going to talk about hip replacements and the management of the patients who have hip arthritis. So when these patients come to see you, they're often not sure if it's their hip, their back, or what exactly is causing their problem. How do you work through that?
Sure. We see a lot of patients that have this issue of thinking it may be their hip when we find out it's in fact their back or vice versa. And sometimes folks have both hip and back problems. The first thing we want to know is what's going on with the patient, how long they've been hurting, and where their pain is. That will help us cue in sometimes on some specific findings. And then we also want to know what things they've tried to help with their pain. Those can help give us some clues to try to decide if it may be coming from their back, their hip, or both.
So oftentimes patients come in and their hip hurts. So that starts the process. Is it the back or is it the hip? What's the first thing you do to help figure out where it's coming from?
After we've gotten a good history where the patient's told us their symptoms or what they're feeling, we'll then examine the patient. A lot of the times there's some clues in that. We also utilize x-rays typically at first to try to get a good idea. Sometimes we need to have back x-rays, sometimes hip x-rays, and sometimes both.
Well, Dr. Stronach, I think I have hip arthritis. Do I need an MRI?
You do not need an MRI. There are select times for both back and hip issues where we do feel an MRI is appropriate, but that's fairly selective. We really like to start with x-rays. Let us take a look. Let us hear what's going on with you. And a lot of the times we can avoid that MRI altogether.
We both know that we see way too many MRIs at the hip before we see patients and that we can avoid some of those studies, right?
That's correct. That's right.
Okay. So when you see the patient for the first time and Miss Smith has left hip pain, you determine it's her hip. Then what do you do? How do you manage Miss Smith's hip?
So we like to start with conservative management if this is a newer complaint or something where Miss Smith has not tried treatment first. A lot of the times this will be simple things like Tylenol and anti-inflammatories if the patient can take those medications. Physical therapy can be helpful sometimes in the early stages of arthritis or other hip injuries. And then we can also use other things such as hip injections and some advanced treatments if those things are not working well for the patient.
And if you're doing a hip injection, what's that like? What do you inject and what do you expect from it?
Right. So hip injections can really play an important role for us in, one, trying to give patients pain relief, but also trying to sort out this idea of hip and back pain. We give a hip injection if we feel like the symptoms are more hip related. And the way that we do a hip injection is we'll typically utilize some type of guidance, whether that's ultrasound or a specific kind of x-ray machine called fluoroscopy, and we'll guide the needle down into the hip joint. We'll provide steroid, which helps with longer-term inflammation, And then we'll also typically put some anesthetic medicine in there, like you'd get lidocaine at the dentist, and that can give a pretty quick response to decrease your pain.
And that numbing medicine plays another role, right? It helps you decide, is it the hip, is it the back?
That's right. And there are times where I tell patients, I'm going to send you for what we'd call a diagnostic and therapeutic injection. And what that means is I'm trying to gather more information, and hopefully we can give you some pain relief. If we give you that injection and you get complete relief of that pain, then that really helps us know that this is much more likely coming from your hip and not from your back.
Sure. Okay, let's say Ms. Smith has she tried the anti-inflammatory medications, the Tylenol. She continued to have pain. She saw you 2 or 3 months later. You did the injection. She comes back 4 months later and said, Dr. Stronach, that really worked well. And I got great relief with the initial injection. It lasted about 6 weeks longer, but for the last 2.5 months, my pain's been slowly getting worse, and I don't like the pain anymore. Now what are we talking about?
Yeah, so at this point, we look at what we've called our conservative treatments, which has been the therapy, the injections, these other things, and the patient feels that they're not really benefiting from those anymore. Another option that we have is to proceed with a hip replacement if the patient is ready for that. There's some things that we want to think through, such as their medical issues, to make sure that they're safe medically to proceed with surgery. And we also want to make sure the patient is ready to undergo surgery.
Great. And, we talked about x-rays. When you look at x-rays, describe to our viewing audience what you're looking for on a hip x-ray to tell you that patient has arthritis that's significant enough that they might need a hip replacement.
Sure. So when we look at a hip x-ray, what we want to see in a normal hip is that we can see the pelvis and we can see the ball of the hip joint, or what's called the femoral head. And there should be a nice space in between those two bones. And that space is actually where the cartilage is. And I'll show patients this on their x-rays in clinic, and it should look like a nice wide eyebrow. There should be a big spot there. Now, if that spot is going away, they begin to develop what we call bone-on-bone arthritis, where the two are touching each other. We'll also see bone spurs. We can also see cysts or holes in the bone right under the surface of the joint as well.
Great, and that's essentially what you see with osteoarthritis, wear and tear arthritis, the thing that we do most of our hip replacements for. What about if the patient comes to see you and they have inflammatory arthritis?
Sure, and inflammatory arthritis is a little bit different. We think about it in a little bit different manner. So this would be things like rheumatoid arthritis and lupus. And sometimes you do not see exactly the same pattern on the x-rays, but we can see quite a bit of damage from this. But most of this comes from the lining causing damage to the actual cartilage surface.
Great. So let's go back to Ms. Smith. You said that you've talked to her. First of all, tell me about your education. I've heard from others in our office that you're the best patient educator when someone's being scheduled for hip replacement because you spend a lot of time really making sure the patient understands. How do you do that?
Well, I like to sit down with the patient, and we'll typically start with a model. We'll come in with we have a real hip replacement in the clinic. We also have a model that demonstrates how that is done, and we can hold that model up to their x-rays so they can see their own hip, and then we can show them what a hip replacement looks like. I like to briefly just go over what's expected leading up to surgery and then what's going to happen on the day of. A lot of folks will have anxiety over that, so we like to talk through that.
Well, tell me about that. Well,
Sure.
Just like I'm Ms. Smith, tell me what she's going to experience on the day of surgery.
Sure. So we explain that they're going to come in that morning. We're going to get them ready. The surgery itself typically takes about an hour, hour and a half, and that I'll see them before the surgery to make sure we have all final questions answered. We do the surgery, as I mentioned, and then afterwards to go to the recovery area. We have a lot of folks that are going home the same day. If they're doing well, we'll get you up with therapy and get you up and get you walking. There's some patients that's not the right choice for or need to spend a night in the hospital. But we really want to get you up and get you mobilized. And I think that's a little bit of a shock sometimes to people. These implants are made to be walked on as soon as we close your skin. You can get up and start putting weight on them, and we want to get you mobile and get you walking. We then go through what we anticipate for the use of assistive devices, and every patient's a little bit different. Most folks are going to be on a walker for a period of time, and then hopefully onto a cane for a brief period of time, and then get you back to independence if that's where we started.
You bet. And, and this is where you develop your bond with the patient, right? You have seen them for a few months, been working through non-operatively. So when you sit down and talk to them about surgery, you've already developed a bond, and now you're really taking that bond and trust to another level, because this patient is now deciding, I'm going to have Dr. Stronach replace my hip. We talk about it like it's a little thing, but none of us really consider it a small thing. We understand these patients are going through a major operation, and we treat it that way, right?
That's right. And I think we all take that very seriously. For me, I like to go through the risks briefly with patients too, that there are things that can go wrong with surgery. We certainly don't want to dwell on that, but it is important to talk about.
You bet. So let's go back. Ms. Smith had your discussion, and you talked about kind of getting them ready for surgery, and it's become known in our area now that that's surgical optimization. Let's talk about optimization. Which factors are you looking for that you want to correct to give Ms. Smith the best possible outcome she can get?
I think that's a great point, and we have to look at each patient as an individual and see what is going on from a health status standpoint. There are specific things that we see pretty frequently that can be issues for us that we really want to pay attention to. One of those is diabetes. It's certainly fine to have a joint replacement with diabetes, but we want to make sure that you're under good control. And so we'll typically check a hemoglobin A1C, which is a long-term way to measure how you're doing with your blood sugars. And I'll counsel those patients. It's super important to make sure your blood sugars are under good control around that time of surgery. We worry about smoking and nicotine tobacco use products. So if someone's smoking, we'll typically encourage that patient or give them counseling to stop. And sometimes we'll even do tests to make sure that that's happened. We also worry about patients from a weight standpoint. Patients that are overweight can have increased risk of problems with surgery, such as wound healing or even infection. And so certain patients we really counsel and want to have them lose weight before we provide surgery.
And what if Ms. Smith's been taking narcotics? If she's been taking hydrocodone, say, for her arthritic hip, because sometimes I know that's not a common treatment plan for you, but oftentimes the patients we see have already been started on hydrocodone or some other narcotic for their hip, or maybe it's for their back, but it might still impact your surgery. So what do you do with that problem?
Yeah, that can be tricky, and some of that depends on if they're on the narcotics for other issues such as back problems, or if they've been placed on them for hip or knee arthritis, which we typically really try to avoid. So we really like to get the patients completely off narcotics if at all possible. There's some patients that we need to taper them down quite a bit, but may have to remain on them around the time of surgery. And the reason why that's so important is that if you're on a really high dose of this pain medication coming in, it's really, really hard for us to control your pain. And the science is now starting to say that we really think there may be some issues, that you actually may be at increased risk of having problems around the time of surgery because you're on these narcotics long term.
It's pretty amazing how many complications seem to have a relationship with narcotics too, whether it's a direct one-on-one or why it happens that way, but the data certainly shows it, doesn't it?
That's correct, yeah, and I think we still have more to learn about it, but we certainly understand these should really only be used in short-term management right around the time of surgery, and we want you off of them as soon as we can.
Sure. So Ms. Smith is worried about blood transfusion. So if she has no other major medical problems and has a normal blood count, she's not anemic, what do you think her risk is of having a blood transfusion by you or one of your partners? So if they have hip replacement, that she would require blood transfusion.
Our risk of blood transfusion in a healthy patient is extremely low. We'd have to go back and look at our most recent data, but we're probably running less than 1%, and I'd imagine even lower than that.
Yeah, why is that? What's changed? Because, for Ms. Smith, her dad had his hip replaced, and she clearly remembers his getting blood after surgery when he had his hip replaced. What's changed in that 35 years?
Yeah, I think that's a great question, and a lot of people still come in and ask me, hey, do I still need to give blood like I used to so you can give it back? And we don't do a lot of those things anymore. There have been a few key points. One of those is a medication called tranexamic acid. We give that to patients at the start and end of surgery, and that helps protect the clot at the end of surgery. It keeps the patient from bleeding so much, and that has dramatically reduced overall transfusion rates across arthroplasty in the United States. That's really been our number one biggest factor of being able to reduce that need to give blood after this type of surgery.
You bet. And some of it is the fact that now we know that patients don't have to have a hemoglobin level of 10, 11, or 12, that they can function at a hemoglobin much lower. And I don't know how much you know about this, but this institution was very important in learning that. when Carl Nelson was here, he was well known for operating on Jehovah's Witnesses and doing their hips. And so we learned from his experience that patients can tolerate a lower blood count and still do very well. And that's kind of the national norm now, right?
That's right. And I remember in training and actually had the pleasure of working with Dr. Nelson and getting to see that his practice with Jehovah's Witnesses. When I was young in training, where I did training, they frequently would look at a number and say, we're giving blood. And so a lot of patients got a lot of blood that we think they probably didn't need. And so we've really backed off on that quite a bit.
Sure. You know, Ms. Smith also heard about this horrible complication of an infected total hip. So what's her risk of having an infection?
The good news for Mrs. Smith is she's healthy, she's motivated and active. Her risk of having an infection is going to be quite a bit lower than 1% in our center. Where we typically run into problems with infection is in the patient population that we talked about. Patients that have what we call multiple medical comorbidities, or basically lots of problems. So if a patient's quite heavy and is smoking and diabetic, their risk of having a problem like infection is going to be quite high. Now, we do a lot of things to try to prevent infection here. We give antibiotics before and frequently after the surgery, depending on the situation with that specific patient.
Right. And so suppose somebody gets an infection. How's that managed?
We manage infection based on the scenario. It really depends on how soon that happens after surgery. Sometimes patients will have a wound problem or develop infection in a very short time after surgery. We want to get that patient back to the operating room as fast as possible to deal with that infection. Other patients that had their joint replaced a long time ago have been doing great, and then all of a sudden they can get an infection in the joint.
How's that happen?
That can happen for a variety of reasons. A lot of the times it will happen because the patient has gotten an infection somewhere else. I've seen it from a dental abscess. Patient will have a urinary tract infection or have had a recent pneumonia. These bacteria can get in your bloodstream and then land around that joint replacement.
Because it's a foreign body.
That's right.
And so it's important with our patients to understand it's a lifetime risk, but that's a risk that's very low. And as you know, we're very proud of our data here that our early postoperative infection rate is very, 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 very low. And I think it's because of a number of things that you talked about. In addition to giving antibiotics, you have a controlled environment. You dress up for your surgery too, don't you? What do you wear?
That's right. Yeah, so you'd think we're trying to land on Mars if you saw us getting ready. We wear coverings over our shoes. We're not bringing anything in on our feet. We wear gowns and hoods that completely seal us in. We spend quite a bit of time cleaning ourselves off in terms of our hands and our forearms before we come into that operating room. We want that to be a completely sterile environment.
Yeah, and you control your room as far as traffic, time the door is open, and you do lots of things that we take for granted that our patients don't realize we do, right? And it's important to them. So Miss Smith decides she's ready. You do her surgery, but before that, she's got a few more questions. Dr. Stronach, I've heard about all these different approaches. Which one are you using and why?
Right. I think we get that question sometimes about approach. My general philosophy is you got to pick your pilot. Find someone that you want to fly that airplane. Did you get on a flight last time and ask them what setting they were going to be on and what coordinates they were going to use? I think first and foremost, the patient needs to be comfortable with their surgeon. There are several different ways to come into a hip to do that replacement. I think of that as several different doors to get into the same room. I need to get those parts in correctly. That's the number one most important thing. And you can do that through several different approaches, but I need to get the parts in and they need to be right.
Good.
That's the bottom line.
So why don't you just talk about the more common approaches so that our audience understands what we're talking about. To them, approach may not mean anything until they heard the words direct anterior.
That's right. Yeah. So typically the main three approaches being used in this area will be what's called the direct anterior approach, the anterolateral approach, and the posterior approach. The direct anterior approach, the incision would be right on the corner of the front part of your hip, and typically a specialized table is utilized to do that type of hip replacement. An anterolateral approach, the incision will be just a little bit further to the side than that. And then in a posterior approach, the incision is typically going to be right on the side of your hip. So a little bit different position in where the surgeon's going to be working to get access to the hip joint.
Yeah, I think what you said is really important. The approach doesn't really matter. what really matters is how the surgeon gets the implants in the right position and how they articulate with each other, right?
That's right.
And the nice thing here is we have 4 total joint surgeons, and all the approaches are utilized. So if somebody's really stuck on having a certain approach, you can refer the patient to one of your partners.
Yep, that's correct. And there's really trade-offs with each approach. We think when we look at these certain topics, each approach is a little bit better or worse for different reasons when you look at each part of that approach.
You know, Dr. Stronach, every time I watch the evening news, Miss Smith, that is, when she watches it, she sees these ads about robots. Are you going to use a robot for Miss Smith's hip?
So we typically do not use robots here. We pay attention to what's going on in the scientific community, and there's a lot of talk right now about robots. To date, we have not been able to have any findings to say that the use of robotics improves the outcome of the patient. So if we decide to use a robot, we may be able to put the parts in 3 degrees differently, but we do not think so far that translates into a better outcome for the patient, both in that initial recovery, but also in the long-term outcome for the implant.
And no decrease in complication rate.
That's right. And there's a learning curve, and there can actually be some issues sometimes with the robot depending on the situation and the training of that surgeon.
Great. And so Ms. Smith has her surgery, and everything's gone beautifully. You've done the surgery in like an hour and 10 minutes. What happens now?
So we go to recovery, and if the patient's planning on going home, we're going to work with that patient through what's called a rapid recovery protocol. And so we're going to do some things to make sure that she feels good that day. She feels confident to get up. We're going to work with a physical therapist to make sure that she's safe. We're going to provide education. We want to make sure she knows what medication she's going to be given, and we get her ready to go home.
And you've already discussed all these things with her multiple times before, so this is just a reiteration of what you've discussed, correct?
That's right.
Now, has she been asleep for her surgery, or was this done under a spinal or a general anesthetic?
Sure. We typically will use general anesthesia here. In previous practice, I've used spinals a good bit as well. They're both very good ways to do hip or knee replacement. There are sometimes where we'll specifically want one of those depending on the patient's underlying issues and medical issues.
Right, and we've published great data from here to show excellent results with the general anesthetic, and many of our patients would rather be asleep for their surgery, correct?
That's right.
And we're fortunate. You feel very comfortable with our anesthesiologist for those that need a spinal or an epidural instead of a general. That's fine too. And some patients want one or the other, correct?
That's correct, yep.
So Miss Smith goes home. What happens now?
Well, so initially for me, I want to make sure that she's up and walking, getting around safely. We don't want you just laying on the couch for 2 weeks. We want you up and moving. So you got to get up and get your own glass of water, go to the bathroom, those kind of things. Typically, the first few days, you will have some surgical pain from the joint replacement. With most hip replacements, that's usually fairly mild, that most patients can tell a difference internally, that the hip feels better already, but they have to get over that inflammation from the surgical part of recovery. So typically, we take it fairly easy the first few days. Beyond that, we really let the patient slowly progress over the next few weeks, and we keep a close eye on you in clinic to help direct that. But we really don't use physical therapy unless you have a specific issue that needs that after a hip replacement.
You mean Miss Smith doesn't need physical therapy? All of her friends have been getting therapy 3 times a week for 6 weeks after hip replacement, and you're telling Miss Smith she doesn't really need that?
We've come a long way. It's pretty crazy with hips. You know, we really consistently are able to do hip replacements and allow patients to naturally recover and not have to go to a physical therapist.
That's great. So Miss Smith goes home and she doesn't have any major problems, but she's had some more nausea than she was expecting. What does she do? She's been home 2 days, and this is 10 o'clock at night. How does she get her problem addressed?
So one thing we have here that I think is fantastic is after hours, if you pick up the phone, we have a phone number for you. And if you call that number, one of us is going to answer that call. The surgeons and our physician's assistants, man or woman, that number.
So not a foot surgeon, not a hand surgeon, but a hip or knee surgeon.
Not a medical student, not a nurse. You're going to get someone who does joint replacement for a living on that phone at 10 o'clock, or sometimes we get that 2 a.m. call. We typically reserve that for emergencies, but also we want the patients to know that we are there and there's a direct bridge back to us 24/7 if they have anything that they're worried about.
You know, you mentioned an important thing. You said not a medical student, but one of us, our team members. Talk about working in an academic institution and the team that works with you.
One of the reasons I like academics is that we get to work with a wide variety of people at different levels of training. So it's a very vertically integrated program. We work with medical students. We also work with people in training, what we call residents. We also have a fellow, so someone who's finished their orthopedic surgery training but is focusing on hip and knee replacement. We also have physician's assistants and nurses. We have a large team of people to help take care of you. The key is that we're the captain of the ship. So in the operating room, we're going to be hands-on. I'm not going to be in the other room having a coffee while your surgery is being done. I'm going to be in there doing your surgery, but I can't do it alone. We have to have a team of people to take care of you in the operating room, but also in clinic and in this follow-up that we refer to be able to really provide you holistic care.
So what can Miss Smith expect 6 months down the road? She's had this hip replacement and she's seen you a few times post-op. So what's her life like now as far as her hip's concerned?
Typically with hip replacement, the patient will usually forget that they've had the surgery. They'll have a rare reminder that, oh, I had my hip replaced. But the vast majority of the time, people can really return to that function activity level that they had prior to their hip pain and hip problem, and really rarely to never have hip pain if that joint replacement is functioning appropriately.
Is there anything you tell your hip patients they shouldn't do after surgery?
I really prefer if my patients don't ride bulls. I don't like that, and I really try to avoid skydiving and bungee jumping. Otherwise, we really let patients get back to normal activities that we'd anticipate for their age. And that can be patients down into their 30s even. Really let people get back to biking and being active. Water sports, things like that seem to be completely acceptable for a hip replacement.
Well, it sounds like we've pretty well gone through the whole scenario of hip replacement. You've talked about patient coming in and having their surgery and their recovery and getting back to normal life. One thing we haven't talked about is the implant. What's the implant made of, and how big is it?
It's really helpful, I think, for patients to be able to physically see what the implants look like. And that's one of the reasons why we'll show them to you in clinic if you want to see them. We've got some laying around. It wasn't inside of patients, the good news. The way that we do the hip replacement is on the pelvic side or on the socket side. We put in what's called a hemispherical cup, and that's basically like you take an orange and cut it in half. It's rough metal on the outside, and that cup is made out of titanium. So we push that into the bone so it'll hold nice and tight, and sometimes we even need to put a screw or two in there to hold it. And then a piece of plastic that's a very high-end piece of plastic will snap inside that. That becomes your new cartilage.
And that piece of plastic, we've had multiple advancements over the last 20 years in plastic.
On the bottom side, we've taken away the ball of your hip joint, and we put what's called a femoral stem, or a titanium part, down in the top part of the femur bone. That also is roughened on the outside, so the bone will hold on to that for us. And then on the very end of that, we'll typically utilize a ceramic ball. Ceramic is what your cereal bowl is made out of, but just like that plastic, we use a very high-end ceramic that's much smoother and much harder than any metal that we have. And so we want that ceramic ball against that plastic liner. That's your new tire, and we want that tire to last a very, very long time for you.
And how long is that? How long do these hip replacements last?
So we can only look back to the past, and I like to tell my patients that we do not grow corn, we grow oak trees, that we have to look over a long period of time to see what we think the results are going to be. When we look back to what we now know is inferior technology to the 80s and 90s, if you had your hip replaced in the 90s, at 20 years, you still had about an 85% chance of that joint being in place and functioning well. Around the year 2000, we had a fairly big change in our world in the making of the plastic and in the ceramic. And as we followed those patients, we see what we call wear rates that are about 100 times better. So we really don't know, and I tell patients that. I would really hope to see a 30-year life expectancy, potentially longer, out of the hip replacement, depending on how much wear and tear has been put on it.
Well, that's a pretty good deal if you can have an operation that lasts 30 years and gives you pain relief and lets you do the things you want to do. And on that, I think we'll close this session. Dr. Stronach, you've been great. I think the audience can have a great idea now of what it means to have a hip replacement. We are so glad that you're part of our team. We look forward to you're having a long career here and taking care of many Arkansans.
Thank you, Dr. Barnes. I appreciate it.
Thanks. Thank you. We hope you've enjoyed the session. This has been certainly fun for Dr. Stronach and myself, and we hope you learned a lot from it, and we look forward to more sessions just like this. We'll have other members of the UAMS orthopedic team to visit with you. Thank you.